Hey, welcome everybody to Mayo Clinic SCAD research presentation. A highlight of this weekend, that's for sure. My name is Jan Szilard. I'm a member of the Board of Directors of SCAD Research Inc. Before we hear from Mayo Clinic in Rochester, Minnesota, I'd like to have us share a brief history of SCAD Research Inc. And also part of this weekend, we want to acknowledge some of the people who have made this weekend possible. So personally, I'd like to thank Dave McGarry. I work with Dave. He helps keep the website running for us. And all these people are volunteers, by the way. And also Nancy Spain, who updates the content on our websites and sometimes drops what she's doing because, you know, we're running behind and she gets that done. Dave also, and sometimes when our technology goes down. So now I'd like to share a brief history of SCAD Research Inc. Yes, I'd like to take make a moment of silence, or take a moment of silence for those like my sister and Bob's wife, Judy, who did not survive, and there's others as well, of course. Thank you. I'd like to take a moment to introduce Bob Allico, who is our founder of SCAD Research Inc. and is also our president. Bob has a few words to say.
Hello, SCAD family. This was a great endeavor to put this together. We wanted to make sure we didn't get past too far without letting all the SCAD family get together, see each other, hear the effects of your fundraising. And again, I'd like to thank Jan, Carol, and Jill Makowski for what I know is to be at least a couple hundred hours of work to put this all together. And before I just make my last little comment, I watched all of this morning's SCAD patients talking. And one thing I've noticed, they said, we'd like to get the word out. And this is actually one of the things to do that. And the other thing is we have flyers on our website for all of you that were so eager, and which I was excited to hear. We have flyers that are PDFs that you can pull down, copy off on your printer. You can bring it to, they're two-sided. You can bring them to your doctor, bring them to the EMTs, and one for you yourself that are all medically checked to be accurate. And we think that that would be a very good thing to do. I just want to tell you that for 9 years, we've been working at this. We have donated to Mayo Clinic and other places, but we have donated to Mayo Clinic $965,000 as of this year. And we're shooting for that million. Of course, you know that. And with the board, when we had our last meetings with the board, I noticed that we're sort of hitting that, well, you hit $1 million and you're getting to a plateau, but I didn't see that with the board. Not having a plateau, it was, where do we go from here? And how do we accelerate it? So I want to tell you that we're putting new items on the SCAD website, to the SCAD store. In fact, one of them is going to be, I'm negotiating it right now. Another nonprofit is going to supply us with scrubs. And they're a 501c3, and they are helping unfortunate people in Haiti. And so with that, I'd like to introduce Carol. I think that is, and she'll talk about a few more people that this big endeavor took to get together.
Thanks, Bob. I just want to take a few minutes to thank a number of individuals and organizations that are very important to SCAD research. And I'm going to start with our very important SCADaddle organizers and coordinators. They are a great group of dedicated, creative, and inspiring SCAD survivors. And especially have done a great job this year with having to unravel some of those plans that were already put in place. Everybody has been just really great about making this this big jump from in-person SCADaddles to virtual. And just to mention their names: Jill McComsey with Lehigh Valley, Pennsylvania, Ellen Robin, who does the West Coast SCADaddle, Kelly Houlihan in Minnesota, and Sarah Trolley and Sonia Perez Morales, who are both taking over the national/Illinois 5K. And then our newest additions, Karen Gugla from Michigan, and Leanne Fries in North Carolina. So this would have been their first annual, and we will make sure that they have their truly first annual coming up in 2021. Also to our technical team, Nick Durazio and Amanda Frisbee. We are so lucky to have them as our technical team. And very early on, we realized that we were absolutely not equipped to undertake this endeavor, and they volunteered to help us out just in time. Finally, just a big thank you to some of our sponsors, nationwide sponsors, Pinkard Family Foundation. We also have an anonymous family foundation. Our presenting sponsor, Blue Cross Blue Shield of Detroit, Michigan. Supporting sponsor is Catalina Charitable Foundation out of St. Petersburg, Florida. And then finally, our patron sponsors, Jefferson Street Pub from Harrison Township, Michigan, Lehigh Valley Health Services in Allentown, Pennsylvania, and then the Dennis family. Again, thank you so much, and back to Bob.
Yes, right now I'd like to introduce the head of the Mayo Clinic research team, Dr. Sharon Hayes.
So I'm Dr. Sharon Hayes, beaming to you from my office at Mayo Clinic. I am joined by a number of my colleagues. I'm going to give you a little bit of our environment here at Mayo. Today it looks sunny, but it's been freezing the past couple of days. I want to thank Bob SCAD Research Inc., and all of the folks who are joining us today, as well as who will view this afterwards, for being a part of our research and being a part of our cheerleaders. As you will hear from all of us today, this is such important research for which we are committed to in a very consistent and persistent way, despite challenges that have to do with this being an under-recognized condition, with this being something that wasn't even known until about a decade ago. I do want to talk about a little bit as I reflect about Bob, because I'm gonna, when I was sharing with my medical secretary, Tony Salver, who some of you may have talked to, she said, I remember the phone call when Bob first called you. And I just reflected, Bob, on how we've really come a long way. We have come such a long way that today we wanted to announce and truly celebrate the hard work of all of you. That would be every single person who has attended a walk, who's asked a question, who's been a part of our research. And I wish I had some cheerleader music right now, but Bob hinted that we needed to go to $1 million, but in fact, over the years, SCAD Research Inc., due to the hard work of all of you, because it isn't just a big entity or corporation, has given over $1 million to Mayo Clinic SCAD Research. This allows SCAD Research to now be designated as a principal benefactor. And for those of you who've seen the benefactor wall at Mayo Clinic, we'll move up to a different section. Now, that all sounds almost unreal, $1 million, when I remember that the first donation was about $10,000. But I can tell you that each one of us, now Dr. Olson, yeah, isn't that a great picture? This is what the money goes to, because Dr. Olson can now do more genetic testing and to understand the mechanism and the genetic underpinnings of SCAD. So that's Dr. Olson, who is our tried and true. His whole team is working on trying to explore, are there any genetic underpinnings that will inform how we can manage SCAD? And we've got Sue Milbrandt, who's joined us on the call today, as well as my medical secretary up in the left, Tony Salver, and April Rowe. All of them have been a part of this because they've taken your calls or helped one of us. Dr. Best and I, you'll hear more from us later. And obviously, so we got mask and unmask. When they're together, we are wearing masks as good Mayo Clinic individuals, but there's Dr. Gulati and Dr. Tweet. So I can't actually tell you, I can tell you, but I cannot fully express what this means to us, as each one of us on the research team here has interacted with you either clinically or through Facebook or through other mechanisms to help advance the science. We know that there are so many answers that are yet to be found, but we also know that the progress we've made, if nothing else, in raising awareness and helping women who go to the emergency department get appropriate care because somebody is thinking this could be a heart attack due to SCAD, and working hand in hand with SCAD research. So as we go forward today with a presentation, I do want to, so there you have it. I don't even know that it fits on the whole screen. We are thrilled to be with you today to tell you a little bit about the SCAD science, what's exciting, what the money that SCAD research has done to help us do this work. And then you'll hear at the end. So what I'd encourage you all to do who are watching on Facebook is type in your questions in the Facebook comments, and we will be monitoring those. And at the end of our presentation, we will have a Q&A session. So I'm joined today by Dr. Marisha Tweet, who will be speaking afterwards, Dr. Patricia Best, who is one of our interventional cardiologists who reads the SCAD coronary angiograms, Dr. Rajiv Gulati, who is also an interventional cardiologist. Dr. Olson will not be joining us today because he is on hospital rounds, and Sue Milbrandt, who you will meet at the end, who is one of our, who is our study coordinator. So I am going to stop sharing and turn things over to Dr. Tweet.
Hello, so I'm Dr. Marisha Tweet. I am also here at Mayo Clinic in my office in Rochester, Minnesota, and I'm very happy to discuss with you some information regarding spontaneous coronary artery dissection, both big level, like higher level thinking, some history, and then where we are at today. I am so grateful to be here. I just need to take a moment to say thank you to SCAD Research Inc. for everything you've done, from both the moral support, the financial support, the encouragement. It's really meant a lot, and we are so grateful and so excited to share with you some information today. So to make sure we're starting all on the same page, I will be talking about spontaneous coronary artery dissection, also referred to as SCAD. This is a cause of heart attack or sudden heart death due to not plaque or cholesterol buildup, but rather a bleeding pocket of blood in the wall of the artery, or a tear within the wall of the artery, or a combination of both, leading to a narrowing of the artery and leading to a heart attack or sudden heart death. It commonly occurs in women, many times who are a little younger, without risk factors, and we'll get into some more details of that. So let's just talk about the timeline and how we all became involved in research. So in about 2009, two SCAD patients approached Dr. Hayes about what we were doing at Mayo Clinic in regards to researching SCAD. That prompted her to look a little further into what was feasible and also to assemble a team. Many of the core members are here, Dr. Rajiv Gulati, myself, Dr. Best, Dr. Olson, and some others. At which time we created an overarching research plan, but also just started simple with a pilot study to see if this was even possible. In 2011, we presented that pilot study data. That was a whole 12 patients. And since then have come a long ways. I was a trainee at that time, thinking that this would be maybe a year-long project and then I'd move on. And I was wrong, as you can see. The study has since was opened for more participants after we saw it was feasible. And what we saw was feasible is, yes, we could study SCAD, but we didn't necessarily have to bring everyone to Rochester to have meaningful research. But as part of that, Dr. Timothy Olson and now Dr. Tamil Turley have initiated a genetics biorepository back at that time and has since made a lot of ground in regards to understanding more about SCAD genetics, which I'll talk to you more about, but have a lot of future plans as well. The registry now includes over 1,200 confirmed SCAD participants, and I'll tell you right now that's an underestimate. But these are patients who have enrolled in the registry with confirmed diagnosis of coronary dissection as reviewed on coronary angiography or other relevant imaging, who have since consented and are participating in our research. And a lot of the participation is primarily based on survey data, but we're continually incorporating novel study approaches and questions, including some prospective studies. And these participants are primarily from the United States, but as you can see, it's international as well. And we have participants from throughout the whole world. This is just a quick look at our demographic. So there you see the number of participants on the y-axis and age in years on the x-axis. And you can see that the median age of patients at the time of their first SCAD who are currently participating in the registry is about 46 years of age. But you can see that there are participants who are much younger than that at the time of their first SCAD and participants who are also much older than that. It is almost like a bell curve. In addition to that, you can see that by the pattern that most of the participants are women, but there are some male participants as well. So there are some men who have SCAD. Now, this is a poster that I presented in 2011 as I think I was a second-year internal medicine resident. And this was our 12 patients that we presented on. And then this is now 2019. So this poster I presented about a year ago at the NIH. And you can see the core authors there, but this is now over 800 patients. So we have come a long ways. And, you know, when we were creating this slide set, you know, we took a step back and thought, you know, reflecting on everything, what is the overarching aims of our program? And this is what I put together. And I think a lot of us would agree on this. And really, an aim is to perform research, you know, with the goal of increasing and disseminating knowledge about SCAD. And we do this by designing and conducting research studies, presenting at scientific, medical, and patient advocacy meetings, publishing in peer-reviewed medical journals, networking on social media, engaging trainees because they are our future, and that's how I got involved. Dr. Hayes engaged me and invited me to participate, and collaborating with others, both within our institution, but also outside of our own discipline. So as cardiologists, we've also worked a lot with radiologists and obstetricians and emergency medicine physicians, and making this a multidisciplinary effort, as well as outside of our own institution. So we have collaborated with colleagues throughout the United States, but also in other countries such as United Kingdom. And we do this in order to fill knowledge gaps. But ultimately, we want to improve the clinical care and outcomes among patients with SCAD or who are at risk for SCAD. And ultimately, you know, in an ideal world, we don't want SCAD to even exist. That might be a little optimistic, but you know, ultimately, we want to help. And these are some oldies but goodies, some pictures that we pulled up. And one of my favorite pictures is the one here in the left corner, presenting one of our early posters at the American Heart Association. And I can kind of tell when it was probably 2011 because I'm pregnant with my second child at that time. And he's now 8 years old. And these are some other presentations that we've given through the years, trainees we've engaged. You can see Dr. Hayes, Dr. Best, Dr. Gulati in these pictures, as well as some other familiar faces. And I like Dr. Hayes' pants in that last picture. But throughout all this, it's been creating a lot of memories as we've worked to disseminate the information as we learn it. And this was one of our first publications, published in 2011, describing those first patients. And since then, we have come a long way. I'll show you some of additional publications kind of as a slideshow that have since come out, but I will tell you that it's not entirely comprehensive. But we've touched upon topics such as what's the prognosis, how to manage SCAD, coronary artery tortuosity, CT imaging, looking for fibromuscular dysplasia, understanding that maybe this isn't so rare, or looking at connective tissue diseases, genetic susceptibility, novel genes, looking at mental health, cardiac rehab, computed tomography, endothelial dysfunction and function, emergency department presentation, migraines, natural history, menstrual chest pain. We've looked at pregnancy after SCAD. We've looked at pregnancy in general, or hormones, or SCAD-related, or SCAD-related, pregnancy-related SCAD, MRI, CT. We've looked at what is known unknown, genetics. And these are some recent genetic papers. And a lot of that information went into a large consensus document that was chaired by Dr. Sharon Hayes, also co-written by myself and Dr. Gulati, along with collaborators throughout the nation and world, for the American Heart Association scientific statement that came out in 2018. In addition to that, with a couple years now with additional information, I would like to direct your attention to a recent 2020 publication, again, a state-of-the-art review about spontaneous coronary artery dissection that was just recently published. And in addition to that, we're not stopping there. We have upcoming presentations at national and international conferences. And these are the ones that I'll highlight that are coming up. These are usually in-person presentations, but because of COVID, they're currently virtual. And I'll also emphasize that many of these presentations, we do engage our trainees. So for instance, this presentation is for the American College of Emergency Physicians, presented by Dr. Alexis Johnson, who is currently in her residency on the West Coast in emergency medicine. And she did a presentation, or will be doing a presentation, on SCAD in the emergency department. And presentation, I mean, that's critical to realize that emergency medicine physicians are hearing about SCAD. They're sometimes the first line role, and that includes physicians, but also other members on the healthcare team. The upcoming AHA 2020 scientific sessions will be this November. We have Dr. Chasen Serez, who will be presenting on exercise and exercise habits and prescriptions in patients who have had SCAD. In addition to that, at the same conference, we have posters, and Dr. Tarabashia, who's one of our internal medicine residents, will be presenting on atrial arrhythmias. The autoimmune disease poster has actually been since accepted as a publication and actually should be published in the next couple of weeks. We also have a poster being presented by Dr. Angie Lobo Ramirez on spontaneous coronary artery dissection associated with pregnancy. And then at the NIH, I will be presenting early data from our prospective echo findings in acute spontaneous coronary artery dissection. And, you know, I could talk all day about SCAD. As you could see, there's a lot of information out there that we've kind of put out through the years, but these next few slides, I'm really going to focus on what we have done over the past year. Certainly, if you're writing in questions, I might not necessarily cover the content of your question, but we will have a panel of experts to answer the questions at the end of this. So again, I'm going to just focus on the publications that we've been putting out this past year, just to update you on where we're at now. And so one of those papers is about mental health, including post-traumatic stress disorder, depression, anxiety. Another key paper is the identification of novel susceptibility loci for spontaneous coronary artery dissection, which was put out by Dr. Turley and Dr. Olson in conjunction with our team just recently as well, which has some groundbreaking information. There's a publication that just came out by our group looking again, updating on the association of pregnancy and SCAD, specifically focusing on patients who have had pregnancies after a first SCAD. But in addition to that, we have written about pregnancy-associated myocardial infarctions with a focus on SCAD. And even in the obstetrics literature, I co-wrote with a colleague, Dr. Campbell, who is a maternal fetal medicine expert at Yale, about SCAD and other causes of myocardial infarction associated with pregnancy. Also in the past year, we have in internal medicine, well, actually he's a cardiology fellow now, write a review about SCAD and etiology and recurrence. We have a focus on SCAD in a collaborative effort about myocardial infarction and non-obstructed coronary arteries that Dr. Hayes had informed, along with a review about non-atherosclerotic causes with, again, an emphasis or inclusion of SCAD by Dr. Waterbury and Dr. Gulati and colleagues, along with another one about myocardial infarction in the young. Again, many of these articles emphasize and discuss SCAD, where in the past, I think sometimes it was ignored or not given part of the spotlight. And then even opportunities to have editorials on SCAD, again, to further discuss the literature with our colleagues. And so let's just do a quick SCAD at 101. SCAD is a cause of heart attack and sudden death, as I already mentioned. The reported prevalence is 0.07 to 1%, but it's likely higher as we're more aware and better at diagnosing it. Mostly women, as you saw in those curves that I showed you earlier, tend to be younger at time of first presentation, but there is a wide range of ages that have been affected by SCAD. Usually patients have minimal typical risk factors, such as high cholesterol or high blood pressure, although some people do have those in addition. It is thought to be the cause of heart attack in young women about 10 to 30% of the time. And one study found that women who were young presenting with a type of heart attack called a STEMI, it was the cause of heart attack in about 20%. Is the most common cause, or at least one of the most common causes, of pregnancy-associated heart attack. It can affect athletes. Symptoms after SCAD are common, and SCAD can happen again. So again, I'd like to bring your attention to the state-of-the-art review. And this art of the review, I won't have time to go over all these topics, but does cover a wide variety of topics, including epidemiology, pathophysiology, genetics, hormones, diagnosis, management. What about after SCAD chest pain management or symptom control, rehab, mental health, recurrent SCAD, reproductive issues. A lot of those are encompassed in this document. And again, when we think about SCAD, we think about the coronary arteries otherwise appearing normal, but at least per information from even our genetic studies and imaging showing the high likelihood of fibromuscular dysplasia, the arteries are probably structurally different. And as a result, some patients or persons can have a blood pocket in the wall leading to narrowing, sometimes can have a tear, and that's what causes the SCAD. And if you read some of the literature, you'll see that it is sometimes subclassified. The type 1 is where there may be an obvious tear. A type 2 is where there's a blood pocket and maybe not so obvious, and perhaps a reason why we didn't always appreciate it, and that's the most common kind. And then a type 3 is probably a little more tricky because often a type 3 also looks very similar to plaque or atherosclerosis related blockages. Something that we have found is that coronary artery tortuosity is common in patients or persons who have had SCAD. And that was something that was even true when comparing patients with SCAD to angiograms of similar aged and similar sex patients who've had angiograms for other reasons. And you know that type 2 SCAD is not always obvious. Those black arrows point out an area where there's hematoma and the vessel narrows and kind of goes away as a result of SCAD. The type 1 looks more like this, where the interventionalists can see a white line where the wall is separating. This particular dissection was from the catheter, but you can see how clearly it is there. And historically, we used to think that all SCAD looked like that. And as we got better with our imaging in the cath lab, we realized that actually most SCAD is a hematoma and maybe not so obvious. And that's partly why we're better at recognizing it. And even when we know that, it's not always obvious. On the left, where that orange circle appeared and where that arrow is, there is a SCAD, but it looks almost like it could just be a small vessel, right? Are we sure it's SCAD? Well, this individual had a repeat angiogram, and sure enough, that vessel had healed up, which we know SCAD commonly does. And sure enough, on retrospect, it was realized that the original area was a SCAD. And why does SCAD happen? You know, that's something we're trying to better understand through research. We think there are some pre-existing conditions that people have, such as arteriopathy, like fibromuscular dysplasia, where the arteries are made differently. That occurs in 40 to 80% of patients. In our experience at Mayo, it's about 65%. Connective tissue diseases. So some patients have inherited connective tissue conditions like Marfan's disease or Ehlers-Danlos, which is probably about 5 to 8% of people who've had SCAD. We have a lot of ongoing research about susceptibility genes and genetic predisposition to the arteries being made differently, probably not a single SCAD gene, but actually a complex conglomeration of multiple factors. Migraine is quite common with a lifetime prevalence of about 40%, at least in our registry data. It is a common cause of pregnancy-associated heart attack, less than 5% in the Canadian experience, but as high as 18% in our Rochester epidemiology project experience. And then hypertension is probably in about a third of patients, and that can also be associated with fibromuscular dysplasia, which we commonly refer to as FMD. And then there's other causes, the first being idiopathic, which means we're not sure. Vasospasm, systemic inflammation has been proposed, and there's been some other theories. Now, in addition to that, there are other environmental factors, which might include intense exercise, which has been associated with SCAD, emotional stress, sex hormones, exogenous, or you could even say endogenous, the hormones we made ourselves, medications and drugs, and even Valsalva and straining maneuvers have been associated with SCAD. And it is not always straightforward. This arrow points out an area that looks almost like SCAD hematoma, but when nitroglycerin, which causes the vessels to dilate, was given to that vessel directly through the catheter, it went away, consistent with the spasm. Now, this patient also had a SCAD of a branch vessel. So this was an example of a spasm and a SCAD. And for some patients who do struggle with chest pain after SCAD, we do wonder if there is some overlap and whether or not a concurrent spasm may be contributing to symptoms, along with dysfunction of the small vessels. I'm going to dive just a little bit into our recent publications because I think these have not been talked a lot about yet, mostly because they're so new. And so I just want to give you a quick summary about them and the major findings from them. This particular paper was on 700, we looked at 782 registry patients who were then contacted, and we received a little over 500 surveys. A lot of these surveys were quite long with multiple mental health assessments. Most of the recipient or participants were women, with only about 2.5% being men, but there were some men respondents. A median age at the time of SCAD was 47 years of these participants, but time of survey completion was 52 years. So there had been some time for some of the participants since the time of their SCAD when they did these surveys. When we looked at the data, 82% of the patients participating mentioned at least having one trauma, with about 28% having mild or more post-traumatic symptoms. And symptoms of anxiety was observed in 41% of patients, and of depression was observed in 32% of patients. When we looked at the description of trauma, over half of it was related to a serious life-threatening illness, which for many patients was their SCAD. When we looked at some other findings, we found that the longer someone was from the time of their SCAD to the time of the survey, they tended to have less high scores for anxiety. When the patients were younger at the time of their first SCAD, and if they had low resiliency scores on those specific surveys, they tended to have higher scores for trauma, anxiety, and depression. There was a specific questionnaire looking at anxiety sensitivity specifically, and those patients who were more sensitive to anxiety symptoms had and reported more severe anxiety and had higher scores on the anxiety-related surveys, as well as post-traumatic stress disorder symptoms. And then on the other hand, the participants who scored really high on the resiliency questionnaires also scored high on the emotional and social quality of life. So how do we make a conclusion from all this information? And I'm just showing you the high points. There were some other nuances that we put into the paper, but the survivors of SCAD had significant, or at least notable rates from our perspective, of PTSD, depression, and anxiety. And this was associated with a lower quality of life, specifically in those who had lower resiliency skills. As a result, we do think screening and treatment for psychological distress is advised for patients. And we think that behavioral interventions targeted at improving resiliency may be beneficial. I'll segue on to another recent publication looking at the association of pregnancy with the recurrence of SCAD among women with a history of SCAD. So this was an interesting one because we looked at this question using 3 different study designs. So I'll walk you through it without hopefully getting too far into the weeds. But we looked at 990 women who had complete surveys and abstracted records. And of those, 636 women were of childbearing age at the time of their SCAD, because that's the population that we wanted to study. And if you look at the yellow box, we did one study where we did what's called a cohort time to event analysis. So what we did is we looked at those 636 patients. We started time 0 at the time of their SCAD and followed them forward into the future and saw what happened. Who had an additional SCAD, who didn't. And then we looked at, well, for those who had another SCAD, did they tend to have more history of pregnancy after SCAD or not? And compared the 2 statistically. In addition to that, of those 636 participants, 23 of those women did have a pregnancy after SCAD. So we also did what's called a case series analysis, where we just focused on those 23 women in the paper and discussed some general features about them and their experiences. And then in the green, so that was the orange box. And then the green text box was the nested case control analysis. So this is a different approach to the data where we looked at all of the patients in that group of 636 patients who had another SCAD. And then we matched them to the patients who did not have another SCAD. And then we looked for differences, with one of the key questions being, was there a difference in whether or not they had another pregnancy? And so I put it in color coding just to try to help differentiate these three very different approaches to studying the data. And in the first, the yellow, we found 122 out of 636 of the women of childbearing age at time of first SCAD, then went on to have another SCAD. So the 5-year recurrence rate, so when we followed these patients up to 5 years, about 15% had another SCAD. Pregnancy after SCAD was not associated with another SCAD. The caveat, which I'll emphasize again later, was this is a small group of women who then went on to have a pregnancy after SCAD. So that affects the statistical power. So anything we get out of the study, we do have to have some great caution about not overinterpreting the data. And then of course we adjusted for a few factors, which we did with all of these analyses. 23 women had a total of 32 pregnancies after SCAD. So looking at that case series and looking specifically at those women, the median age was 38 years, which is a little surprising to me. So these were slightly older mothers. 2 of the women had another SCAD after their pregnancy. The others did not at time of follow-up. Of those 2 women, one was 9 weeks postpartum, and she had a very significant SCAD. She was actually included in the first report we put out a few years ago. And then the other woman did have a second SCAD, but it was many years after her pregnancy. So it wasn't in a time way directly correlated. And then when we looked at all of the women who had recurrent SCAD and compared them to match controls, or people who didn't have recurrent SCAD, and matched them based on certain characteristics, there was no difference in regards to the rates of pregnancy after SCAD between these 2 groups. So in conclusion, most of the women we found tolerated pregnancy and lactation after SCAD without evidence for increased risk of recurrence. So the study tells us, okay, there's complex contributors to SCAD recurrence. It's not just one thing or the other. Like, okay, if someone gets pregnant again, they're not automatically going to have another SCAD. However, as I already mentioned, we do interpret these results with caution because there is a selection bias and there is a small total number of women. And there are other confounders that we just can't possibly account for due to the nature of how these studies are designed. And one example of that selection bias, for instance, is all these women had a normal ejection fraction. So there are probably other factors that played into the role of them going on to have another pregnancy. And I just want to emphasize that the hemodynamic changes that occur with pregnancy, and we have shown previously that pregnancy-associated SCAD is associated with a severe presentation. And those are important reasons that we still discourage pregnancy after SCAD when counseling patients. But on the other hand, I think this data is very informative to patients and women of childbearing potential in particular, because I think it's important we give all the data we can as people make important life decisions headed forward. And then I'll just talk a little bit about the genetics, because we've had some very important papers come out. Now, my disclaimer is I'm not a geneticist. Dr. Timothy Olson is covering the hospital service right now, so I'm doing this on his behalf. So please forgive me. I'll do my best. So SCAD is probably in the middle between an inherited condition like Marfan syndrome, which, as I showed you, probably is about 5 to 8% of patients who've had SCAD. And there's probably a genetic component, and it's probably complex genetics. And so that's kind of the other end of the spectrum where we often see, say, typical coronary artery disease. And there's many different ways of trying to understand the genetics of SCAD. And these are techniques that Dr. Timothy Olson, Dr. Tamil Turley, and the lab, because there's a big group of people, have been working on through the years to look into. And one important finding that was done with our group in collaboration with colleagues across the globe include the finding of the factor 1 endothelin 1 genetic locus. And to essentially summarize, is there is an allele carrier, the A allele, that's more commonly associated with SCAD as well as fibromuscular dysplasia, as compared to the opposite allele carrier, the G allele, which we more often see in people with coronary artery disease and myocardial infarction. And this is specifically on the factor 1 locus, which has some known pathways in terms of how it affects the vasculature and the signaling within the blood. In addition to that, Dr. Turley identified a rare tailin-1 missense variant, which is not in every patient, but a subgroup of patients, both familial patients, but also sporadic non-familial, so people who don't have other family members who've had SCAD. And this is a variant for a gene that encodes a protein that is important for the structural integrity of the arteries. And this particular one stains in the coronary arteries. So again, is important and also hypothesis generating in terms of how to design the next experiments and what to focus on next. And then finally, I really want to emphasize this most recent publication, which I'll keep simple because a lot of it is above my own head, which looked for specific genome-wide significant susceptibility loci associated with SCAD. And in this project, they were able to identify 3 significant loci as well as 7 loci that were of mention that are associated with SCAD. And that project included what's called a discovery cohort, where they first looked, just in general at 484 women with SCAD, but compared that to women who did not have SCAD to look for differences. And then this also included a replication cohort, which means they found these signals and then they took a whole new group of patients and made sure that they could reproduce those results. And essentially, in summary, this study identified positional candidate genes associated with SCAD that have already established associations with other non-coronary or extracoronary arteriopathies, which just means that these genes candidate genes have been associated in other conditions that affect the arterial structure, and we're seeing them in SCAD. And this is very helpful and important for directing those next steps of research, not only for identifying genetic markers, but trying to understand the mechanisms of disease. What at the molecular or structural level contributes or causes someone to have a SCAD? And as we try to understand that, then we can try to better understand other interplays, like the environmental interplay or the interaction with other disease states. And what about the future? So I think this slide oversimplifies this future, but really to summarize some of the key things that we're looking at next, not entirely comprehensive, but I had to fit it all in one slide. One of the things is the whole genome sequencing in both familial and recurrent SCAD is on the future in regards to our ongoing genetic studies. Looking for identifiers for SCAD recurrence risk, and hopefully with that knowledge, also just trying to better understand who is at risk before they even have their first SCAD. Trying to understand arterial physiology in patients who have SCAD and how that might be different in someone who doesn't have that history. Looking at the echocardiographic findings, some of you have participated in our echo study here in Rochester. We have finished collecting all the data and now are working on the analyses. Other topics that we have been focusing on include autoimmune diseases, hormones, pregnancy, arrhythmias, general outcomes, implication of novel imaging, biometrics, and then of course just collecting clinical data as we head forward to continue just to understand how patients do going forward and what the different rates of complications and so forth are, with just the goal of better understanding and being able to better inform both our clinical practice but also our research. And we're continually trying to improve how we do that. That's also a work in progress. So again, I just want to thank you for your attention. I want to thank you for the support. I am just so grateful to be a part of this. When I started helping with this way back, I guess 2009, 2010, I thought it would be 1 year and then I'd be done, but instead it has become a huge part of my current career path. Unexpectedly, I would have not predicted that maybe 10, 12 years ago, but I am so grateful it has. I've learned so much along the way. So many of you have taught me so much. I can't go into it enough. It's been such a joy to care for women and men who have had SCAD. Such a joy to participate in the research and continue to try to be creative in how to move forward. And I just want to thank you for that. And then with that, I will stop sharing my presentation and I think we'll open it up to a question and answer.
Yes,
So-
and if all the Mayo presenters can turn on their cameras, we'll go ahead and start the Q&A period.
So welcome back and thank you. I am looking for my team to come back on. There have been a number of questions that have been submitted. Some are on, I've been trying to take them and follow as Dr. Tweet was speaking, because there's a bit of a theme to some of them. And I'm gonna start with some questions for Dr. Gulati, actually, if you'll unmute yourself so I can ask you, because you were on specifically about Dr. Alid's paper on tortuosity. So it's the 2014 paper reports that coronary artery tortuosity is associated with higher recurrence. Is there a degree of tortuosity that would lead you to prescribe metoprolol? So that's one part of it, and there's a couple of metoprolol. Another question, and I'm grouping those, is tortuosity always present? And is it considered a form of fibromuscular dysplasia? So I'll let you sort of start with that, and maybe Patty, you can join in as well.
Thank you. Can you hear me okay, Sharon? Great.
Lean a little into your mic.
You bet. I'll try and speak a little louder. This is really a great question. I'm going to try and answer both of them separately. The first one, does tortuosity change your management? I think it's what it's saying. Not directly, but I will say that because tortuosity or severe tortuosity was associated with a higher risk of recurrence, and because of that other study that shows that beta blockers may reduce the risk of a recurrence, I think it's just an extra push to recommend a beta blocker. So really to try hard and prescribe and take the beta blocker. But we will typically prescribe beta blockers in all of our patients. So just an extra push, but not kind of a decision point to do and don't prescribe. The second, regarding tortuosity and fibromuscular dysplasia, it was strongly associated. So when we did that study, the tortuosity was strongly associated with fibromuscular dysplasia in the non-coronary arteries. It's speculative, but I think it's logical to think that tortuosity is a type of fibromuscular dysplasia in patients who've had SCAD. We do know from other studies looking at ultrasounds of the carotids and the vertebral arteries that severe tortuosity is a feature of fibromuscular dysplasia in those vessels. So it's logical to think that it's all part of the same pattern of abnormality. But do we have specific evidence to say for sure? I would say no is the answer to that question. Marisha and Patty may have more information in that.
So one of the things, just to chime in on that, is that tortuosity itself, you can see in other conditions, and Rajiv and I, both from seeing caths over the years, oftentimes people who've had hypertension for long standing and in a much older population, we see tortuosity. So tortuosity itself does not tell you that someone has fibromuscular dysplasia, but it is a feature that may run along with it. And so it's not exclusive to it.
All right, so I have another question along the same lines, because it's must be a highly attentive and reading the literature. So in 2017, SAW paper reports associations between metoprolol and lower rate of SCAD recurrence. They don't seem to distinguish between those who are hypertensive from those with low blood pressure. So do we recommend metoprolol for people with low average blood pressure? And there's a sort of a similar or a related question. Some people who have seen other perhaps patient of ours on this team that are recommending metoprolol for just a year. I will take that to start, because I think it's important that many of the papers that are coming out about SCAD, including ones that are coming out from Mayo Clinic and our registry, are what we call observational, right? So what we're doing, we're not taking a test or a procedure or a drug and applying it to one group and then another group and seeing how it turns out. We're just looking overall at whether somebody elected to take a beta blocker or the doctor prescribed versus not. And so what we see is there may not be a cause and effect, really important concept. But what that study did show is that those who were put on a beta blocker versus those who were not had fewer recurrences. They did not differentiate between those who had high blood pressure and low. My personal approach, and I'd love to have my colleagues weigh in, is since that's one of the few things that has been shown to perhaps be associated with a lower risk of recurrence, and because beta blockers after heart attack do lessen the risk of arrhythmias and other things, and are also used if people have reduced heart pumping function, that it seems reasonable in patients who can tolerate them to use it afterwards. What I don't do is say it's required, because people have low blood pressure, they have side effects, and I say the evidence is soft. So if you feel lousy on this, I think you can stop it. And maybe some of that what people read about a year came from, I tell patients, like, if you can tolerate it, I would like to see you on it for about a year, and then let's regroup and make a decision. So that's a bit what I have. And then there's a follow-up question that's about aspirin that we'll take as well. So I think we all have similar but slight variations on our own practice, in part because the evidence isn't strong one way or another. Marisha, Rajiv, Patty?
I know everything you said is perfect. I totally agree. And maybe the one thing I would add is if there is a randomized trial that happens, then I would encourage people to think about volunteering to study that question, whether one drug is better than another drug or no drug. I think, you know, we need to know, and I think a randomized trial will give us an answer.
I would agree with everything that's been said. In general, one of the questions that Dr. Hayes brought up was whether or not some of the data is really supporting that we should be treating with antihypertensives more aggressively. And so in general, my practice with SCAD patients is if their blood pressure, I don't let their blood pressure run even borderline high or anywhere close to that, that I want it to be in the lower range of normal. And again, whether or not they can tolerate them. And if you're going to put someone on a medication to lower their blood pressure, the beta blocker is a great choice. And then the other ones that we all would typically use as another option as a great choice would be an ACE or an ARB. And so that's kind of my practice. And again, some of these patients who've had really low blood pressures can't tolerate a beta blocker. And I don't think there's enough evidence to push someone to be on it.
I would agree with everything that's been said as well. I think one other caveat is I do push the beta blockers a little harder in those who have a dysfunction in their left ventricular pump function. So if someone's told their ejection fraction is low, that is a guideline-directed therapy for heart failure to help promote recovery. So I try a little harder in that. And then I do sometimes try different types of beta blockers before saying, oh, we can't tolerate it, just again, to see if we can get any benefit, even if it's a smidgen of a dose for a short period of time early on. And then, you know, of course, there are some where you feel worse on the medication than better. And then you start asking, are we really, with the amount of evidence out there, are we really doing benefit or harm? So it's always that risk benefit assessment for each individual.
I think one overarching about any of the treatments, preventive or otherwise, that have been proposed as potentially beneficial, none of them carry the weight of evidence that your doctor should be saying you have to be on them. And I would include aspirin. And I think that's one of the things in the state-of-the-art review, and we had folks from Mayo, from Canada, from England, that were on that. And it was sort of a consensus on aspirin and Plavix or a dual antiplatelet therapy. And the evidence wasn't such that we could do it. And so my own practice has been to lean back a little bit about aspirin, particularly aspirin for lifetime after SCAD. We do not believe that SCAD is due to a blood clot, which is what aspirin treats. I think it's probably reasonable, but again, I reassess that at a year, and in a woman or man who is having a lot of bruising or bleeding or other things, I don't think the evidence is there. And Rajiv, I think you have, I would love for you to take a question about both aspirin and Plavix or dual antiplatelet therapy and help the group sort of know the difference and when they might be used.
Yeah, no, thanks, Sharon. I mean, yeah, I just want to echo everything you're saying, that there's nothing that is so hard, fast, because we don't have the data to support it. But the two antiplatelet drugs that are commonly used in people who've had some sort of heart attacks are aspirin, Plavix or clopidogrel, and there are other ones that are like that, either a single one of each or in combination. Someone who's had coronary artery stents or even just balloon angioplasty, but particularly stents, does really need to take both of those drugs because they're working on the stents. They're stopping the stents from closing with a blood clot. And the time period after the stents, it varies, but typically 12 months sometimes, or 6 months to stay on both of those, after which you can drop one and stay on the other one long term. That is not to treat the SCAD, it's not to prevent another SCAD, it is to stop the stent from closing with a thrombus or blood clot. In someone who has SCAD and who does not need or have stents placed, that's a whole different question. And as Dr. Hayes says, we've tried to come to some sort of consensus, but no one has a strong weight of evidence to support one way or another. We have this competing theory. On the one hand, we think SCAD might be due to that intramural hematoma or bleeding in the vessel wall. So if you take that side, then maybe you shouldn't be giving more blood thinners like aspirin because it might make the bleeding worse. On the other hand, you don't want a blood clot to close the vessel, and so you want to keep the blood that's flowing a little bit thinner. So most of us say, well, let's go pragmatic and not overdo it with the blood thinners, like combining two of them, and just take a single baby aspirin as one tablet to try and minimize the risk of a blood clot from forming in the coronary artery while not exacerbating the bleeding in the vessel wall. Again, I don't think we have the solid evidence. I do know that there's a number of people that are interested in studying this, and maybe if the clinical trials happen, we may get some more information in time to come.
Here's a question, and I'll just because you've been looking at our data so closely, Dr. Tweet. So one asks, what is the rate of sudden cardiac death in presentation of SCAD? And then another, or the rate of STEMI, and maybe start by what's a STEMI versus NSTEMI in terms of that. There's been a couple of questions just for clarity about that.
Mm-hmm. And I will also ask Dr. Best to weigh in on the sudden cardiac arrest because she's done a lot of work on that too, and has had a poster presented. Cardiac arrest presentation is probably currently about, in terms of when we look at the current registry data, is probably about 12% of participants who presented with a cardiac arrest, give or take a little. I might be remembering slightly off, but that's a rough proportion. And those are the participants who presented with cardiac arrest, but were resuscitated and were identified as having SCAD. So say there was someone who had a cardiac arrest and passed away and no one realized it was SCAD, we wouldn't be including those in those numbers. And that is a challenge that we're still trying to better, understand in terms of overall rates of SCAD. In regards to STEMI versus non-STEMI, so there's two types of heart attacks. One's called a non-ST elevation myocardial infarction. That presents just like a heart attack, except the ECG looks a little different than what we call an ST elevation myocardial infarction. So both are types of heart attacks, but the ECG distinguishes the two with the thought that if the ongoing injury to the heart muscle is diffuse and going all the way through the muscle, and many times that will present a little differently on the ECG. And of course, Dr. Best and Dr. Gulati, if you have other ways of explaining it, feel free to chime in. But essentially, when we look at those two types of heart attacks, many times patients participate or presenting with a STEMI, an ST elevation myocardial infarction, are brought immediately to the catheterization laboratory and revascularized, because many times we anticipate that the vessel will be fully blocked off in those situations. Whereas a non-ST elevation myocardial infarction, sometimes those participants, if they're otherwise stable, will, it's not elective, but perhaps not as emergent to be brought to the catheterization laboratory. In general, some of our earlier studies show that perhaps they're about equal in prevalence, but as we've gone on, as we're getting better at detecting SCAD, we're seeing actually a higher proportion of patients with non-ST elevation myocardial infarction than ST elevation myocardial infarction, but you're still seeing both. So patients with SCAD can present with sudden cardiac arrest, ST elevation myocardial infarction, which is known as STEMI, non-ST elevation myocardial infarction, which is known as non-STEMI, and sorry for all the words. And then rarely we do think there are situations where patients present with what's called unstable angina or chest discomfort, but maybe the troponins haven't bumped, but that is extremely uncommon. Usually it presents with one of the other three. And I think Dr. Best, it'd be nice to hear your thoughts on this as well.
So as Dr. Tweet was saying, the ST elevation myocardial infarctions, we know that if when we see the elevation on the ECG, those people actually have much worse outcomes with any type of myocardial infarction if we don't bring them to the catheterization laboratory quickly and get that blood vessel open. And so that's why they are kind of a more emergent category, and the non-ST elevation myocardial infarction, as long as they're doing well and not having ongoing chest pain and everything with medications, it's fine to treat them that way. The data that we have on people having sudden cardiac death or ventricular fibrillation along with SCAD really is that it goes along the same way that anyone else who has a heart attack goes. And so that when we've looked at the data and looked to say, should we be more cautious because of the potential of recurrence of SCAD? Should we be putting more defibrillators in? Should we be doing different things? The data really doesn't show that. And just like with any heart attack, when there's lack of blood flow to part of the heart, you can get these bad rhythm problems. And that's how sometimes people present with their heart attack. And it doesn't appear that women who have SCAD have a higher risk or a lower risk or should be treated really any different than the guidelines, which would support only if the heart pumping function is reduced or if someone's having recurrent problems with their heart rhythm, should you need to do something else for them.
Thanks. Well, here's a shout out I just wanted to lift up to everyone because I think it does speak to the impact of you telling your stories. Thank you, Dr. Tweet. Your papers are making a difference. My doctors had read the latest research 2 days before my SCAD. My college dorm mate had read my Facebook post and saw my video and knew to go to the ER when experiencing SCAD symptoms postpartum. Thank you for sharing that with us because, I do think that if we say nothing else, there is definitely a raising of awareness of SCAD by emergency medicine physicians, by cardiologists across the country. And it is because of patients who are speaking about their stories and helping educate their doctors, including us. So thank you very much. I'm going to pose a question because it's common. There were a couple of kind of specific questions, but about exercise. One of the things that we know is that many people want to be physically active. We have cardiac rehab that tells people that they need to be to start an exercise program that would be standard, but people are being given varying exercise prescriptions. We get a lot of questions about very specific things, and there were a couple of specific questions about planks, about lifting, about heart rate limits. I'm going to let you start, Marisha, with what you say. I'll share what I say, and then what the evidence is, which we will all say is somewhat lacking. So go ahead.
We all here care for SCAD patients, so I'd be curious to hear what Patty and Rajiv say to their patients too, because there's probably a little bit of a spectrum, a variety, and some of it depends on how risk averse you are as an individual too, because as Dr. Hayes will get into, the data is very limited, and this is a challenging question to study ethically as well, right? So typically what I tell patients is, one, we do have good data to tell us that cardiac rehab after a SCAD is helpful, both for physical and mental health. And so I encourage all of my patients after they've had a SCAD to participate in cardiac rehab, or even if they have another one, which we never hope would happen, but let's say they have another heart attack, to again participate in cardiac rehab to kind of get back, into the game in terms of exercise. Because even though we know SCAD has been associated with extreme exertion, or even exertion like that's not considered extreme, and whether or not that's a coincidence, I think we're still sorting out. It's really important that patients don't become sedentary. So what I try to encourage my patients to do is participate in moderate activities, which often is guided by the guidelines that have been given and worked up to through the course of cardiac rehab, if you have a good cardiac rehab team, which I know there's some geographic variability in regards to that. And then I often have patients work through to perceived exertion, which on the Borg scale might be kind of between a 12 to 14 in terms of like doing moderate exercise, but not going beyond and pushing them through those really hard walls or becoming competitive. In regards to weightlifting, I encourage patients to do weightlifting as part of their exercise, but to have good form, maybe focus on more repetitions and less weight. Again, I don't give hard limits for things like heart rate or blood pressure or weights, in part because I've found that incorporates a component of anxiety. It's really hard to accurately monitor on one's own. But also I have a sense that perceived exertion is kind of a better way, especially if you're prone to other symptoms like chest discomfort. I think I'll let someone else comment about some of the other activities like planks and those sorts of things, but that has to do with fibromuscular dysplasia and SCAD, and the thought that certain positions might cause tension or unique torsion on some of your arteries and may predispose to other concerns like dissections in other arteries, or avoiding heavy valsalvas, which increases the intrathoracic pressure. Both hemodynamically, there's a huge change both with heart rate and blood pressure, but also increases that chest pressure. So trying to avoid those heavy bearing down activities. But I'd love to hear from some others because it could go on and on too.
Yeah. So our vascular colleagues who treat FMD, because there have been rare reports in the literature about somebody getting a carotid dissection after going to a chiropractor, or going on a roller coaster, which would have your head going back and forth. That's very different than having a coronary dissection because the neck's not moving. So I think that there are some things that you may have read, and there is a theoretical risk of doing that, but that has led to some concerns that are probably not concerns. Can I get a massage? The only way I could even imagine a massage somehow being harmful is if you massaged an artery, and nobody goes around the front of the neck and massage, not anyone I've ever had. So I think that the overarching is exercise is good. Exercising to extremes of competitive exercise to exhaustion, boot camps and other things where the whole intent of it is to be exhausted, we advise generally against. Specific to planks, people who do planks properly do it with proper breathing. Planks done properly are not a problem. If you are bearing down and holding your breath, then that is improper. So I think the point that Dr. Tweet was trying to make, if you use good technique, if you've got if you go to a gym, and if once COVID's over and you can go to a gym, and you get somebody who is coaching you on how to do exercise properly, all of that is probably fine. If you have to hold your breath to lift something and bear down and go, then you should stop doing that. And that's in the gym, that's moving furniture, that's moving rocks in the yard. So again, not everyone is at risk from these heavy exercise, but it is with an abundance of caution because some people have had a SCAD shortly after doing things like this. Patty, do you have anything to add?
Yeah, so I actually use a lot of the same words that you do in my description. So I find that amusing because I've had, you know, a lot of people, if you say, you know, don't do heavy lifting, don't do, you know, those kinds of things. A lot of people go, oh, yeah, I wasn't planning to, but I've had some people who do we're doing aerobics, you know, 8 times a week and, you know, all kinds of different things who will sit down and go, can I do this? Can I do this maneuver? And what I then say is if you can breathe through it, or if you can talk through it, then basically you're fine. And so again, anything you're talking through, you're okay. And so that helps with the, am I doing too much? I then also, pretty much anyone who has SCAD, I recommend against traumatic sports or traumatic activities. So bungee jumping, I tell them not on my recommended list, and other things, just again, because really high stress, sheer stress to someone who has SCAD, even if we didn't pick up anything else in their other vasculature, probably isn't in their best interest. That would be the other things I add in.
Yeah, there's been another comment specifically about zip lines. And again, a zip line is a zip line is a zip line is not the case, because there's some, you know, there's some that we take preschoolers on around here that are little things. And I've been on one that's a mile long in South America that was quite thrilling, but still had a very good deceleration.
Right.
Right. And I think what we're talking about is those things. The other question that we sometimes get is doing thrill sports that aren't necessarily high intensity, but maybe done in an atmosphere like scuba diving or downhill skiing. And one of the things that I talk to individuals about is perhaps taking that first year off, often because it's not just physically not ready to do something like that, but perhaps mentally not quite ready. And then having and making sure that you're in good shape and fit before doing that, and recognizing that if you have a cardiac emergency 30 feet down, scuba dive, regardless of whether you've had a SCAD or not, that's a bad thing because of the environment.
Right. And then with downhill skiing, I also always worry about people going to high elevations and not giving their body time to adjust, and also being cautious with the temperature and being aware of your body. So not going out in extreme cold either.
Right. So, I'm going to shift gears a little bit because some of this is around testing. So one question is a quick answer is, should everyone who's had a SCAD heart attack be tested for FMD? Well, the idea is you're not being tested for FMD. That's a common shortcut that people say, but in fact, you are being tested because of the very high, up to 70 or 80% of patients who've had a SCAD actually have abnormalities in blood vessels across their body. FMD or no, that just happens to be the most common. We're less interested in whether or not you have FMD, actually, because often the FMD is quite mild and something that does not need to be treated or managed. But do you have complications for FMD? Do you have another aneurysm or a dissection in another part of your body that we would either need to treat or to follow? So the recommendations for after a SCAD is that everyone should have a one-time scan from brain to pelvis. And depending on what that shows, they may need some follow-up testing. And that was another question, is how often or do we need follow-up? And that really depends on what is found on that first scan. Because if it's a clean scan, we do not expect that you're going to have an aneurysm develop during your lifetime. They take a long time. On the other hand, if there's something that needs to be monitored, and in rare cases, we have found something that actually required referral for treatment. The other one I'm going to toss to Dr. Tweet is because I think it speaks more to imaging in general. So is a stress cardiac MRI with contrast a safe test? And what are the benefits of this test versus stress echo? And maybe you can just frame imaging after SCAD with commenting on those two tests.
Sure. So there's a lot of potential imaging after SCAD, the invasive imaging, for some reason to look at the coronary arteries again, invasively, like a coronary angiogram. But then there's CT scans, computed tomography, which can look at the coronaries or the arteries elsewhere. That's how we commonly look for things like fibromuscular dysplasia or aneurysms. Sometimes when patients are having additional symptoms, we consider doing a stress test. And even under that umbrella, there's a lot of different subtypes. There's stress tests with exercise. There's stress tests with medications. So you can either exercise and then have imaging to tell you, maybe what the heart's doing at rest compared to exercise. And you can receive a medication that causes your heart to physiologically exercise, somewhat synthetically, so to speak, and then see what happens before and after. And typically, it's unique for each individual. And that's why physicians usually evaluate their patients in clinic before deciding that someone should go on to have a stress test. Typically, any of those options are fine to do if a patient is deemed suitable for being stressed to begin with. For instance, if I had a patient in the hospital actively having a heart attack, I'm not going to be putting them through a stress test. And then the imaging, there's different nuances to the different imaging techniques. Echocardiography is on the chest, so they do the images on your chest and they either put you on a treadmill or give you medication, and then they do the images again. They have to move fast in real time to get those pictures. They ask people to hold their breath because the lungs get in the way. Whereas with, say, a nuclear study, that's actually where you're injected with something like technetium, which causes the heart to light up, and then they use a camera that you sit still in. The differences between those two is the amount of radiation, but the images look different and you get different information. And it's up to the referring cardiologist to decide which information they'll get. Now, MRI is just a similar thing. You're doing a stress test and you're looking at images of the heart before and after. It's just a different imaging approach and you get slightly different information. And you're usually given a contrast injection of something called gadolinium or similar. And again, you don't have metal in your body, there's a checklist of things, you don't have an allergy to the contrast and so forth. It can also be a very suitable way of assessing the heart at rest and with stress. And why do we do this? If we're concerned that the heart's not getting the blood it wants to see, doing a stress test with imaging before and after and the response of the heart to that can give us a lot of information. And the different nuances may change what exact information we'll get.
So thank you. I want to direct this because it's a question that was asked, but it's so often asked to me in clinic. And I'm going to, and how do I tell if my artery is healed? I'm going to, the way you tell it's healed is by looking at it. And I think that if you're doing, the thing I often will say, if you're doing great, it doesn't make a difference at this point. But Dr. Gulati, I'll let you take, since you've rejoined us. I know you're in the middle of patient care. But maybe go over why or why not we would even seek to learn that, particularly in the patient who's doing great.
Yeah, if there was a zero risk way of knowing it, I think we'd all want to know, we'd all just do it. The key is that there's always a risk of doing a procedure. And if finding out isn't really going to change any management, like Dr. Hayes says, then we feel the risk is usually not worth taking. Now, there are some times when it is worth taking a small, but a real risk of, for example, repeating an angiogram. And that might be if the diagnosis was uncertain. For example, the first time the supposed dissection was diagnosed, sometimes repeating an angiogram and showing that it's healed really gives you evidence that it was dissection in the first place. A cholesterol plaque, for example, would not show signs of healing down the line. So there are some good reasons to do that, but most of the time we don't because of the small risk involved. And we know that if someone is doing well clinically, if they're feeling well and doing okay, almost certainly weeks down the line, the vessel will show signs of healing. And while the curiosity and the psychological wish to know it's healed is there is that small risk that's involved. The one thing to throw in there, we do know from lots of studies now from all over the world, really every continent, that late after SCAD, and by late I mean a month and beyond, that there's almost always good healing. But there is a risk in those first week, I would say, first 1, 2, 3, 4, 5, 6, 7 days of the SCAD from progressing. And progressing meaning actually get worse over the first few days and causing more problems. So the healing does happen later, but we can't say definitively at a first SCAD that it will heal in the first few days. There is that higher risk period that we usually advise people about, either keeping them in hospital to observe them or making recommendations to come back if there's any worsening of chest pain over a few days. I've covered a few things there.
Yeah,
but
thank you.
I hope that helps.
Yeah, so I'm going to shift gears again because it's very topical. So there've been a couple of questions about COVID. I personally, from many of my SCAD patients, have asked, one, in the news and in the medical literature, we know that COVID, people who are infected with COVID, it can affect the heart muscle, the heart arteries, increase blood clotting, as well as pre-existing conditions being a risk for a more severe disease. And so maybe just talk about what advice you are giving to patients with SCAD in terms of, is there anything that they need to be particularly worried about, with the caveat, this is an expert opinion because there has not been any studies specifically about SCAD and COVID. You guys in the cath lab, perhaps.
Do you want to go ahead? I just got one thing to say, but you can go. You go ahead.
Go ahead. You can start if you have something to say in particular.
The one thing is that, you know, we're 6-7 months into this pandemic now, and this applies to heart disease in general. But one of the real problems we're seeing is people not presenting to hospital because of concerns of COVID, where and that's been, it's been some really sad cases of people presenting very late with end-stage heart attacks, severe complications because of the fear of COVID. So I would say that if you think you're having a heart attack, you know, forget the COVID. Hospitals are by and large extremely safe, and it's way more important to get your heart attack dealt with than worry about the risk of COVID in hospital. That's the only thing I want to say on SCAD.
I will completely agree with Dr. Gulati on that one, that all across the world, we've seen a decline in people coming in with their heart attacks, and we think that more people are having them at home. And so that is an issue. From a patient standpoint, I think the risk is a little bit variable along our SCAD population, where if someone's had a larger heart attack, that's probably a bigger issue. I advise everyone fairly much the same, where I say you take all the precautions you can, and wearing a mask, socially distancing, all the things that we all should be doing to try and avoid areas of where you're likely to get infected. I've had a number of people where I've had to write letters for them to help with work situations and other things. So I think that, you know, the best you can do to keep yourself safe is what to be doing for everyone. And that includes our SCAD population. And so there is no specific data on SCAD and COVID. I would think that it would be one more risk to have if you developed COVID is if you've had SCAD, because that you're probably more at risk for other events to occur, but we don't have any data.
So I'm going to take our last question before we wrap up, because we're getting to the end of our time. But there have been several questions, and maybe we'll just do each more summary, because they're on a theme in terms of, okay, I've had a SCAD. Is there anything that I should do differently for my siblings or my children? Like, should they get tested? Should they get screened for anything? Should they get genetic testing per se? And let's just start with what our findings have been in terms of what we can test for genetics. First, there's no SCAD gene and there's no FMD gene. So we're starting right out that there isn't a way for us to identify somebody who's definitely at risk. The second is, on the current standard panel of genes that are available to test for, that are more for aneurysms and dissections, only about 4 or 5% of SCAD patients have one of those abnormalities. So for genetic testing, only children or siblings of people who had one of those tests would warrant further genetic testing per se. I'll toss it out to maybe Marisha. What do you tell patients about any screening or treatment for their kids or their siblings?
So one other thing that we've observed by the nature of this registry is, you know, I had mentioned over 1,200 participants, and of those 1,200 participants, we do have some families with SCAD, say sisters or aunt niece or mother daughter. It's variable inheritance, but it's only about 1% of the whole cohort. So if you think about it, 99% of our patients cannot name a relative who's also had a SCAD. And, you know, maybe they have a distant relative who maybe had a questionable aneurysm, or maybe a cousin with FND. So there's some of those nuances, but by and large, most people do not have a family member who will also have or have had a SCAD, even though there are some exceptions. So what I tell people is, you know, your family members could live in fear of something that will never happen to them. So currently, other than what Dr. Hayes already mentioned regarding genetics and, you know, kind of that 5% or so that might have a inherited connective tissue disease, otherwise we don't have routine screening for other family members of those persons who've had SCAD. Now that all changes if someone, say, has suspicious symptoms. So let's say, you know, I'm a woman who had SCAD, and then my daughter just had her baby and now is having funny chest pains. You know, we wouldn't ignore that. We would tell them, you go in, you make sure they know your family history, because of the concern that there are some families that have it. But I don't tell people, don't tell your kids to not have kids, or don't tell your sons to not play competitive sports, because there's not enough data to justify the disadvantages of doing that.
Thank you. There's several questions that are more aimed at Sue, actually, who didn't turn her camera on, but how do you stay in touch with Mayo research? How do you get in touch again? Perhaps you thought about being in research and then you lost the forms that we sent you. So you can go to our website, or you can email, and it's in the chat function. The other question is, okay, I'm in your research. I want you to stay up to date with what's going on with me. How do I get current records? So you can do the same thing by sending it to us, to Sue Milbrandt at mayoscad@mayo.edu. We also send out periodic follow-ups questionnaires. If you think you are not getting those, if you haven't heard from us and you think you're in your study, also reach out to us. Maybe we don't have your current contact information. And we definitely want to hear from you, even if everything is going great. That's a great piece of data for our prospective study as we move forward. As we wrap up before the next bit, and I turn it back over to SRI, do any of my colleagues have anything they want to say to wrap up?
I'll go. Thank you, everyone, for your attention, for your commitment to SCAD, for being involved, for sharing stories, for letting other people know how you're doing, because really it's so helpful for our patients when they can reach out and find someone else who's had SCAD, when people know more about SCAD, and we thank you so much.
With that, I'm going to turn the presentation back over to SRI, to Jill McCumsey. Jill is a SCAD survivor, a Women Heart champion, and a member of the SCAD Research Inc. Board of Directors from Pennsylvania, and founded their SCAD Walk there. Welcome, Jill.
Thank you. Thank you, Dr. Hayes, and thank you to the entire Mayo Clinic team. It's a real pleasure to once again hear from you on the updates of the research that you've been doing. Just to share a little bit about me, I had a SCAD in May of 2012 when my kids were 2 and 3 years old. It was very early on in Mayo Clinic's research, and actually the fortuity of the timing was that my event occurred on the weekend of the very first SCADaddle in Chicago. So I was diagnosed. I was told that this is something that the doctors don't know anything about. It's a fluke thing. And when I returned back to my hospital room, an internet search later revealed that Mayo Clinic was actually doing research, and that there was an opportunity to participate in the research and to support the research. And I immediately took steps to go to Mayo Clinic. So if you're someone who was newly diagnosed and feel like you need some additional information, please consider first of all, getting involved in the research and sending your information, but also if you feel like you need more information, Mayo Clinic is a wonderful resource. I was diagnosed with fibromuscular dysplasia at Mayo Clinic and have been working towards helping both fund the research at Mayo Clinic and continue to empower other patients to learn as much as we can about this disease process. One of the things that I wanted to talk to survivors about is, that part of finding resiliency, at least in my own experience, has been to find a purpose in all of this. And it was such a great opportunity for me to become involved initially after my SCAD with SCAD research and really putting effort into helping SCAD research continue to grow and to continue to raise more and more money, because when I had my event, there were no papers yet. Mayo Clinic had just started doing the research, and there wasn't information out there. And what a blessing it's been to watch as the knowledge base has grown, as the data has been collected. When I joined the SCAD survivors group back in 2012, there were about 200 survivors, and I remember, how exciting it was every time we added another 100, and here it is. Now we have thousands of survivors. The research has grown by leaps and bounds. In fact, I want to send a shout out to the Lehigh Valley Heart Institute, the local hospital who's been supportive of our Lehigh Valley SCADaddle here in Pennsylvania. Dr. Feiner in particular has been able to take the research that Mayo Clinic has published and provide information to local survivors and support local survivors. So the research dollars that we're raising are having a very big impact on local doctors having the knowledge base to be able to diagnose and treat patients all over the country, and particularly here in the Lehigh Valley. So the most important thing that I want to impress upon all of you is that your money and your efforts to raise money for this cause are making a big difference, and we hope to be able to empower you and encourage you and inspire you to continue those efforts and to build on them. And we want you to get involved. So if you have any interest in helping us spread the word about SCAD, to raise money for SCAD, please reach out to SCAD Research. We need you, and Mayo Clinic needs you to help continue to get answers for patients. I wanted to, before I close, I wanted to thank all of you for tuning in and listening. I wanted to also give a special thanks to Carol and Jan for their efforts. Behind the scenes, Carol and Jan have been working tirelessly to put all of this together, to tie up all of the loose ends and make sure that everyone's coordinating and make this weekend possible. In addition, I want to thank the other members of the board. In particular, I wanted to thank Pete for his efforts. Pete is the treasurer of SCAD Research and has done a lot to keep us up and running. So I thank you all again, and hopefully some of you will be joining us this evening on the Saturday night wrap up. Thanks very much.